So now let's talk about the renal excretion of drugs. As we remember, the kidney is the most important organ for drug excretion. If the kidney is not working for most drugs, we can assume that the excretion is impaired and the levels of the drug or its metabolites can build up and cause problems. So renal excretion is the sum of the drug that is filtered minus the drug that is reabsorbed plus the drug that is secreted at the level of the nephron. This here is the nephron. The nephron, I'm going to write it out here, is the functional unit of the kidney. So let's relate renal physiology to pharmacology. So drug comes in at the afferent arteriole, which splits into these glomerular capillaries, which are enveloped in Bowman's capsule. Now, at the bottom of these capillaries, at the basement membrane, there are these slit pores which allow drugs of a certain size to get through and to be filtered. Drug that is not filtered will leave via the efferent arteriole, and this efferent arteriole branches into another capillary plexus called the peritubular capillaries. Now, just as the name implies, peri, around the tubules. These are surrounding the proximal and distal convoluted tubules of the nephron, and this allows another opportunity for that drug to be secreted if it wasn't filtered. Also, drug that is filtered has an opportunity to be reabsorbed here. And so the drug that is reabsorbed, or the drug that is not secreted, can then leave via the renal vein. So let's spend a moment here and talk about each one of these steps and relate it to pharmacology. So the first step is filtration. Now, filtration doesn't really care if the drug is metabolized or unmetabolized. We can filter both types of drug, metabolized or unmetabolized. However, what filtration differentiates between is free versus bound drug. And really, only free drug can be filtered. So what do I mean when I say free? Well, remember that some drugs can bind to plasma proteins, specifically to albumin. So drugs that are unbound to albumin can be filtered at the level of the glomerulus. Albumin itself is too big to get through. And if you see albumin in the urine, that is a problem. And frequently, we use albumin as a marker to determine the progression of kidney disease in diabetic patients, something called microalbuminuria. So small amounts of albumin in the urine. If those levels go up, we know this patient might be having kidney problems. So after filtration, we then get to reabsorption. Now, reabsorption is a good thing and a bad thing. We want to reabsorb a lot of the stuff that is filtered at the glomerulus. We want to reabsorb salts. We want to reabsorb sugar or glucose. We want to reabsorb amino acids. And a lot of that is happening at the proximal convoluted tubule. But what we don't want to reabsorb is drugs. Now, it's important to remember this. The whole point of metabolism was to prevent reabsorption. And the reason here is that reabsorption, it prefers lipid-soluble drugs. Lipid-soluble drugs. And as we remember, most drugs need to be somewhat lipid-soluble to get across the GI tract and be absorbed into our body. So, but once those drugs get to our liver, we have, remember, phase 1 and phase 2 metabolism. What those do is that they change the drug and make it more polar. And by making it more polar, it prevents reabsorption. Now, that's the way that our body does it. Fortunately, we can also manipulate the pH of the urine so to add a charge onto uncharged drugs. So we can change the pH and charge. And by changing the pH and charge, we can prevent the reabsorption of certain drugs. This is a concept that we're going to cover in a future video, and it's called ion trapping. By making something charged in the urine, we can then prevent reabsorption. It has nothing to do with filtration and everything to do with reabsorption. Remember that and don't be confused by it. And so step 3 is secretion. And for many drugs, this is the way that we get rid of it into our urine. And finally, when we take the sum of all of these, we get our urinary excretion.